Good evening, everyone. Thank you so much for joining the lecture with us. Today, Dr. Sanjit is again with us. Last time also he gave an extensive explanation on approach to hemorrhagic stroke. Now we are going to discuss about ischemic stroke, how to approach and what are the new management updates that are there. Thank you so much, sir, for joining us. Over to you, sir.
So, good evening. So, let me thank the Department of Medicine for inviting me for this talk, and which will be on management update on acute ischemic. So, first of all, you should know when to use the term stroke. So, usually the term is used when there is a damage to the brain caused by abnormality of the blood supply. And this term stroke should be used only when the symptoms begin abruptly. So there are many other pathologies which takes place in the blood supply where the patient can develop deficits over a period of time. So those things cannot be termed as stroke. So abrupt onset symptoms is called stroke. Now we'll be dealing with this subject in the following three headings. First, we look at the pathophysiology of an acute ischemic stroke. Then we'll see how we can assess a patient who comes in the acute phase and what treatment we can give him in the acute phase of ischemic stroke. So first, coming to the pathophysiology. So there are basically four mechanisms which can cause acute ischemic stroke. As you know, one is the embolic strokes, second atherosclerosis. Then we have the low flow or the and the lacunar infarcts. So we'll just go through these four pathologies in detail because the management for that these will be slightly different, especially when you look at the long-term management. So this is a cartoon which we'll be seeing again and again. So just imagine this is a patient. This is the internal carotid artery, which is going inside the brain and dividing into the middle cerebral artery. And there are some perforators which is sticking off from the middle cerebral artery. And finally, the middle cerebral artery is dividing into the M1, M2 branches. And here we have the anterior cerebral artery, which goes and supplies and finally branches out into smaller branches. So embolic strokes occur when there is a clot or a thrombus which comes from outside the brain, which enters through one of the major vessels inside the brain and blocks one of the arteries. So there are a lot of high-risk sources for embolism. One is the main thing is the mechanical prosthetic valves. You can have patients with atrial fibrillation, flutter. Occasionally, you can have a patient with the LV thrombus, which can cause a big stroke. Recent MI, this is often an under-recognized source of cardioembolic stroke, as well as dilated cardiomyopathy, infective endocarditis, and sometimes you can have a patient with a large segment of the left ventricle, which is akinetic and which can gather thrombus and this can get dislodged. And also atrial myxomas, and India, especially rheumatic heart disease is still relevant. And also check for patent foramen of ovale, especially in young individuals. Apart from this, you can get strokes occurring from the carotid. If you have a large carotid atheroma, a piece of it can break and go up and cause embolic stroke. So often under recognized ones are the dilated cardiomyopathy and left ventricular akinesia or hypokinetic segments. Now, recently there is a new entity called embolic strokes of undetermined source. So these patients have non-lacunar infarct, which is subcortical in location, and it has all the imaging signature for embolic stroke. However, these patients have all the cardioembolic sources are absent. There is no carotid disease to cause artery-to-artery emboli, and other causes like arthritis, etc., should be ruled out. Then only we can say that the patient is having embolic stroke of undetermined source. So Whatever. So a lot of studies have looked at this because what the best treatment to give for these patients, and if you investigate these patients in detail, what we find is it's actually a heterogeneous group of risk factors for causing this cardioembolic stroke. First of all, we have the aortic arch atheroma. So you can have the arch filled with atherosclerotic plaques, which can get dislodged and cause embolic stroke. Another group is the paroxysmal atrial fibrillation. So these are patients whose atrial fibrillation can be missed if you do only a routine Holter. These patients might need to have a prolonged Holter, weeks or even months, or implantable monitoring devices to pick up this paroxysmal AF. Another group is the paradoxical embolism that is caused by the patent foramen of ovale, and cancer-associated group where the blood is in a hypocoagulable state and can potentially cause embolic stroke. Now coming to the second major group, that is the atherosclerotic stroke. So here you have atheroma building inside the intracranial vessel slowly over a period of years. And then one fine day, what can happen is the plaque can rupture. So often we think that the atheroma occludes, but that's not the case. Usually there is a rupture of the aortic plaque, and this can cause a sudden blockage of the artery and cause a large stroke. So there are a lot of local factors and systemic factors which can influence the rupture of the plaque. The systemic factors like smoking, uncontrolled diabetes, dyslipidemia, high homocysteine level, all these things can act on the plaque and cause plaque rupture. There are also local factors like inflammation in the plaque itself, and you can have a plaque which is very unstable and cause a rupture. Next, we have the low flow or hemodynamic strokes. So these are the strokes which can occur when there is a sudden drop in the blood. So just imagine this patient who's having narrowing of the intracranial vessels. So the blood flow to this part of the brain is already compromised because there is a like narrowing of these vessels due to atheroma buildup. So in this patient, if you suddenly drop the blood pressure, you can have what you call as watershed infarcts, because the area here is supplied by both this artery which is narrowed and this artery which is good, and suddenly you can have compromise in the blood flow and have infarcts in the distal areas. So usually this is caused by cardiac arrhythmias, patient getting a heart attack where you have a hypotensive episode. And another common thing we see is giving patients blood pressure medications. Suddenly the patient who's used to having a high cerebral perfusion pressure, the blood pressure suddenly drops, then also you can precipitate a watershed infarct. So these watershed infarcts can be divided into external and internal. So external watershed infarcts are the ones which is occurring between the branches of the middle cerebral artery and the anterior cerebral artery or the posterior cerebral artery on the cortical surface. And the internal watershed infarcts are the one in the region of the brain supplied by the penetrating vessels from the anterior cerebral and the middle cerebral arteries. So you can have two types of watershed infarcts. And this is a diagram which shows various types of watershed infarcts. And most commonly, you get incomplete types of watershed infarct, as you see here. And the classical sign, named sign for this is a string of pearl appearance of the infarct. Now coming to the fourth type, which is the lacunar infarcts. So these are affecting very small penetrating vessels. And for a long time, we thought this the etiology for this lacunar infarcts were a condition called lipohyalinosis. But right now, a lot of research have gone into this. We know that there can be various mechanisms which can produce these lacunar infarcts. So when do you call infarct lacunar? So there is a strict criteria for that. If you have on a CT, if you see an infarct which is less than 1.5 centimeters, or on the MRI you is less than 2 centimeters, then only you can call it a lacunar infarct. Now, so this will appear something like this. You have a lacunar infarct in the thalamus here. Now coming to the mechanisms, as I told you, initially it was all thought to be due to hypohyalinosis. So that is still one pathology where you can have this pathology called hypohyalinosis affecting the terminal part of the small penetrating artery. So this is a large artery from where you have a branch coming and supplying the brain. And this is the hypohyalinosis which affects the terminal part of the penetrating vessels. Second pathology is you can have atherosclerotic plaques at the ostia of these vessels, at the area which takes off from the main vessels and cause a lacunar infarct. The third thing which is a lot of literature is written about is something called BAD, that is branch atherosclerotic disease. So you have this vessel, big vessel here, and you have the branch of this vessel, the smaller artery. You have an atheroma sitting here, okay, at the branch. So this can potentially occlude this artery, smaller artery, and cause a lacunar infarct. And also even a cardio-embolic stroke can produce a lacunar infarct. How this does is, the embolus can occlude the ostia for some time, and then it can move forward or get it can melt. But when you see the scan might appear like a lacunar infarct. So there are a lot of mechanisms which can produce lacunar infarcts in the brain. Okay. Now, apart from this, there are other common and not so common causes which can also be seen in your practice. First of all, you can have carotid or vertebral artery dissection. And in some areas where sickle cell disease is very prevalent, you can get sickle cell disease itself causing stroke. And other rare things like CADASIL can also be seen presenting with strokes, especially in the younger population. So when you see a patient with a stroke, you need to classify the stroke according to the etiology, because the long-term management is totally different for each of these group. So you use the classification called the TOAST classification, where you have large artery atherosclerosis, you have embolic strokes, you have small vessel disease, that is a lacunar infarct. You have strokes of other determined etiology like dissection, SLE, all that. Then you have strokes of undetermined etiology, and rarely you can have strokes where you evaluate them fully and you couldn't find any cause, and these are called the cryptogenic stroke. So almost 1/3 of all ischemic stroke which occurs in the young population will be cryptogenic strokes. Also, you should know that there is some geographical difference in the types of stroke you see. So if you look at the Western countries, and you see a lot of carotid disease, whereas in India and other Asian countries, you see a lot of intracranial atherosclerosis. So as you move towards the east, the carotid disease comes down, and ICAD, that is intracranial atherosclerotic disease, increases. Also, in the east, you see a lot more small vessel disease, and you have the sickle cell belt around the Mediterranean and the Arabian countries. And in the Far East, especially in Japan, you have a particular arteriopathy called the Moyamoya disease. So depending on where you are, you can have that particular subset of strokes being very common. Okay. Next, we'll see what happens when vessel inside the brain gets occluded. So you should be knowing this: the cerebral blood flow to preserve the brain function, the gray matter, the cerebral blood flow should be around 60 ml per 100 gram per minute. And in the white matter, it should be at least 25 ml per 100 gram per minute. So let's see what happens when there is a occlusion of one of the major vessels. So immediately the blood flow in the vicinity of that occlusion drops drastically to around 10 ml per 100 gram per minute. And that area will get infarcted. And this area is called the infarct core. Now, if you look at this area here, you have this area is actually supplied by this artery and as well as this artery. But now this occlusion has caused only 50% of the blood flow remaining in this place. Okay, so that much of blood is enough to keep the brain going for some time. And this area is Penumbra. Right. So in the acute phase of stroke, you have two areas in the brain, one called the infarct core and another area called the penumbra. So this penumbra area has enough blood going to, for the neurons to sustain the resting membrane potential. So they won't die immediately. So how is this area called the penumbra maintained? One is mainly by the leptomeningeal collaterals. You have the external carotid artery, which goes through the scalp and supplies the pial collaterals, as well as the vessels from the other arteries, which is on the surface of the brain. So this is a major source of blood for this area called the penumbra. Second is, as soon as there is an occlusion, you can have cerebral auto-regulation. So as you know, the body tries to maintain the blood flow inside the brain through a mechanism called auto-regulation. So whatever BP is from 50 to 150, the blood flow will be maintained either by vasoconstriction or vasodilatation. So when there is an occlusion, there will be all the blood vessels there will be vasodilating to maintain the blood pressure. So these are the two basic mechanisms, one cerebral auto-regulation and pial arteriole. Some other things happens at a microcellular level. The penumbra, in the area called the penumbra, the brain tissue, there will be some genes which will be turned on immediately, which will increase the oxygen extraction fraction of whatever blood is flowing in that area. Okay. Now, whatever happens here, you cannot sustain the penumbra for a long time. So finally, what will happen is the area called the penumbra also gets incorporated into the infarct core and you'll get a large stroke. So this occurs within the first 6 hours. So you have a small window to intervene and save the area called the penumbra. So that is the whole thing about treatment of acute ischemic stroke, how to salvage the area called the penumbra. Right. So next, we will go on to the assessment, how you will assess a patient when he comes with a stroke. So you need to assess him both clinically and by imaging. So when you see a patient, these are the 5 questions you will be asking. First of all, is it a stroke? Second thing is stroke. Third, what is the likely etiology? And then how severe is the stroke? And is there any acute intervention possible for this particular patient? So the first question is it a stroke? This is very relevant because there can be a lot of stroke mimics. So this can be easily remembered by the mnemonics medics. So M stands for migraine. So patients with migraine can have sensory deficits, or even rarely you can have something called a familial hemiplegic migraine, which can actually present with hemiplegia. Then you can have white matter diseases like multiple sclerosis, collapse of MS patient can mimic a stroke. You can have a mass tumor in the brain which can suddenly bleed and cause sudden deficit. Epilepsy is very common mimicker of stroke. So especially the post-ictal state, the patient can have what you call as Todd's palsy and electrolyte imbalance. All the electrolyte imbalance, including hypokalemia, hyperkalemia, and hyperglycemia. Everything can cause, can present like a stroke mimic. You can have dissection of the aorta, even a disc prolapse. Suppose you have a cervical disc which is mainly pressing on a motor root, and patient can present with a one arm weakness, and which can also mimic a stroke. Intoxications very common in the younger population. Also infection. The patient may be having a CNS infection going on, like a TB meningitis. If you don't take a good history, you might miss it. And TB endarteritis may be presenting like a stroke. You can have contusion, trauma, conversion reactions, and S stands for secondary metastasis in the brain. And subdural hematoma, especially in the older population, they may not notice that, or they may not give a history of a subtle trauma and maybe having a subdural hematoma which can present like a stroke. So how do you assess? You have something called the FAST, that is face, arm, speech, time test. So you ask the patient to smile and see whether there is any deviation of the face to any particular side. You ask the patient to raise both his hands and see whether there is any drift. You ask him to speak something and see whether the speech is clear and also whether he is understanding what you are saying. And if all three are there, you have to suspect a stroke and act fast. Now, the problem with this fast is it can potentially miss posterior circulation. So there is a newer tool called the B fast. That is, you add two more things to this. One is balance, any imbalance the patient is having, or dizziness, or also blurring of vision, or any hemianopia. So this is the B fast tool, screening tool for stroke. This is one study which was done in our department, published 2 years back, where we looked at the stroke mimics. So what we found was almost 20% of all the referrals we get as acute stroke, in fact, are stroke mimic. And the most common mimic was seizure. So most of the time the patient comes with Todd's palsy. They may not give a history of seizure, or the seizure may not have been witnessed. Another common mimic was peripheral vertigo, which can be a mimicker of a posterior circulation stroke. So whenever you see a patient, make sure it's not a stroke mimic. As important as mimics are what you call as stroke chameleons. So these are stroke with atypical presentation, and you might think this is something else and miss the whole stroke. For example, this is a patient who had presented with a lower element type of facial palsy, like a Bell's palsy. Okay, so in fact, what this patient had was a small pontine infarct. So this is another patient who is an elderly man, irregular on ischemic heart disease, irregular on medications, who presented with a history that he kept on telling that the room is dark, switch on the light. And also he was complaining that his wife is not giving him food. In fact, the plate of food was placed in front of him. So what he had was a posterior circulation stroke in the occipital area, which is causing a hemianopia, cortical blindness. So these patients may not have any motor deficits. And this is another series we had published from our department. The example is a 30-year-old lady who had presented with severe drowsiness, and after that she was remaining mute. So this is a bilateral thalamic infarct. Here also you won't have any deficits, but they can have sudden drowsiness. So these are all examples of stroke chameleons, and you should take a careful history, look at the risk factors, and then you may not miss it. And the problem is most of these stroke chameleons can get missed on a plain CT scan. So if you are suspecting a chameleon, you have to get an urgent MRI. Right. So the next question is, where is the stroke? So what do you mean by where is the stroke? The first where is whether the stroke is affecting the anterior circulation or the posterior circulation. So what do you mean by anterior circulation? So that is all the areas of the brain which is supplied by the internal carotid artery and its branches is the anterior circulation. And the parts of the brain supplied by the vertebro-basilar system is the posterior circulation. So as we saw earlier, posterior circulation stroke may not have any weakness. Like they can just present with sudden nausea, vomiting, instability, severe vertigo, drowsiness, or low GCS, or a visual field defect, which you can easily miss if you don't examine. Now, I'm sure you'll be familiar with this table, how to differentiate anterior and posterior circulation stroke. So in anterior circulation stroke, you can have what you call as an uncrossed hemiplegia. You can have contralateral weakness of the contralateral limb and face. Whereas in posterior circulation, you can get a crossed hemiplegia, where you can get ipsilateral facial weakness with contralateral limbs getting involved. Vision, if the anterior circulation is involved, it will be mainly involving the whole eye. The patient will complain of blindness of one eye. Whereas in posterior circulation, you will have field defects like homonymous hemianopia, etc. Speech, in anterior circulation, you will have language dysfunction. You can have expressive aphasia, any aphasias. Whereas in posterior, you can have dysarthria. Sensory deficits, if at all in the posterior circulation, it will be ipsilateral face with the contralateral limbs. And also cerebellar signs and multiple cranial nerve involvement is more common with posterior circulation strokes. So if you don't examine visual field and face, you can miss out a lot of facial sensation. You can potentially miss out a lot of posterior circulation stroke, and also make sure you just do a basic cerebellar sign examination. Now the second where is whether the first where is whether the patient is having a anterior circulation or a posterior circulation stroke. The second where is whether the involvement is in the cortex or in the subcortical location, right? So this is very easy because there is a large cortical stroke. You will have all the cortical defects like aphasia, visual field defect, hemi-neglect, or cortical sensory loss. If it is subcortical, which is usually seen in lacunar strokes, you can have a pure motor stroke or a pure sensory, or what you call as a ataxic hemiparesis with a pontine lacunar infarct, or a clumsy hand syndrome, which are all classical presentations of lacunar strokes. So here again, examination of the visual field is very important. Examination of a cortical sensation is also equally important. Right. Next, we'll come to the question, what is the likely etiology in this particular patient? So here, you need to do a systematic examination. So first you look at any cardioembolic source. So you examine the pulse and make sure you palpate the pulse for at least a full minute, not to miss out any arrhythmia. You auscultate the heart. You ask for a history of recent MI or obviously mechanical valves or a past history of rheumatic heart disease. Also check for features of congestive cardiac failure and also all the peripheral markers of infective endocarditis. Carotid strokes, you have to palpate the carotid arteries. Also check for bruit and make sure you ask for history of neck trauma in the last 2 weeks, especially in the younger population. And for intracranial artery, you look for any other ischemic events which has happened in other vascular beds, like a MI or a peripheral artery disease, because these patients will be vascular paths with multiple vascular bed involvement, and they'll be having hypertension and diabetes. Also, in patients with intracranial large vessel disease, you might get a history of a hypotensive episode. Like a patient has gone to the doctor 2 days back and he was given a new antihypertensive, or his antihypertensive medicine was hiked up. So this history will be helpful. You have small, for lacunar stroke, there's nothing much other than the history of risk factors. And also, if especially since you take a history to, if you're suspecting a coagulation disorder, any family history of thrombosis or DVT, or the patient had a earlier DVT, and whether the patient, especially female patients, whether they were taking any hormonal preparations, either OCPs or any other treatment for menorrhagia. And also you look for markers of SLE and other collagen vascular diseases. So this is so all patients in the acute phase also, you can do a quick survey of all these possible etiologies. So the next question is, how severe is the stroke? So you had gone to the emergency room to see the patient. You want to report to your senior, okay, there's a stroke. So he's asking you how severe is the stroke. So there is a standard way to do this. That is by doing the NIHS score. I'm sure all of you should be familiar with this score. So this is a score composed of 11 items. The maximum score you can get is 42. So you can download this app on your phones, and next time when you see a patient, you can score them. So a score of anything from 5 to 15 is a moderate stroke. Anything less than 4 will be a minor stroke. And scoring more than 21, it means it is a severe stroke with a very bad prognosis. And also the NIHS will tell you something about the artery which is occluded. So if you're scoring around 9 to 12 in the first 3 hours, it's likely that this patient is having a large artery occlusion, which I will come to it in the next few slides, because this is very important from the management point of view. Right. Now, the last question is any acute intervention possible for this patient? So what are the options we have? One, we can give him IV thrombolysis, or we can combine this with a mechanical thrombectomy. So before we, even if we have the options of treating the patient, we have to look at 3 things. One is the time window, whether this patient is within the time window for treatment. Second, by doing imaging, we have to see whether there is salvageable brain tissue. Third, whether the patient is having any absolute contraindications against giving him therapy. So these are the 3 things we should be looking at. So coming to the time window, so all of you know, for IV thrombolysis, you can give up to 4.5 hours. Mechanical thrombectomy, you can extend the window up to 6 hours. But now there are a lot of studies where shown that you can extend this up to 12 hours and even more. So the first is, how will you radiologically evaluate this patient? The first is to rule out a hemorrhage. Okay, and whatever you do, the recommendation is, if you have a patient who has presented with an acute ischemic or acute stroke, you should be completing the imaging within the first 20 minutes of his arrival in the emergency room. Okay, so that is have to be very fast. Now, what are you looking in the imaging? So what you want to look for is the 4 P's of stroke imaging, as you call it. So what are the 4 P's? The first P is the pipe. So you'll have to look at which pipe is occluded in the brain. The second P is the parenchyma. So you'll have to see how much of the brain parenchyma is already infarcted and gone. The third P is the penumbra, whether there is enough penumbra for us to save. And the last P is the peripherals. That is whether this particular patient is having good collaterals to keep the penumbra going before we intervene. What you call as the 4 P's of stroke imaging. And we'll see in the next slides how we can go about it. So for the first P, that is the parenchyma, you can use a plain CT scan or a MRI. In the MRI, you have to order for a diffusion weighted sequence. So this is a patient who has come 60 minutes into the stroke. So on the top, you have the CT scan, and below that you have the MRI, which is done almost at the same time. So what you see, the CT looks almost totally normal, whereas you can pick up the diffusion restriction very early in the MRI. So MRI is always a better tool to look at the early changes caused by the stroke. As early as 15 minutes, you can see restriction diffusion on a MRI in a patient with a ischemic stroke. So on a CT also, you can make out some changes if you look for them very carefully. There are certain signs. One is called the loss of insular ribbon. So you can see this is the insular cortex here. If you compare with this side, you can see this is totally flattened. There is a sign called the loss of insular ribbon sign. And this is another example of early CT changes in a ischemic stroke. So you can see this area, you can see that it is nicely seen here. Whereas on this side, which is affected by the stroke, the sulci and gyri is ironed out. It's like one sheet there. So these are all early parenchymal changes caused by CT. We can see it on CT scan in a patient with ischemic stroke. However, MRI is a better tool. Now, if you want to quantify the area of the brain which has been involved, you can use what you call as an aspect score, where it is a 10-point score. The lower the score, that means the more area it is damaged. Aspect score of 0 to 4 means it's a very poor scan and the patient is unlikely to benefit with any therapy or planning. Okay. Now the next P is which pipe is involved, which is the blood vessel which is blocked to cause the stroke. So here you can use either MR angiogram, or if you are doing a CT, you can use a CT angiogram, which involves giving a dye. So it's very straightforward. So on a plain CT scan also, sometimes you can make out some evidence that a vessel is blocked. So this is a what you call as a MCA dot sign. You can see there is a small dot here, which signifies there is a small M2 branch which is occluded. Similarly, you can see here what you call as a dense MCA sign. Here, this is seen, there is a occlusion of the M1. This means the stroke is bad and a big stroke. And here you can see similarly like a dense MCA sign. You can see here, this is a pons. In front of the pons, you have the basilar artery. And you can see the basilar artery is looking dense. So this is called the dense basilar sign. So these are all signs on a plain CT itself where you can pick up the vessel which is occluded if you look carefully for the signs. Coming to the next P, that is the peripherals or the collaterals. So here you might need to use special imaging like the multi-phase CT angio. So here you can see you give contrast and do the what you call as a MIB projections, and you can see the spinal collaterals here. So this is an example here. This is a patient with, there are 3 patients here. This patient has this vessel which is occluded, but you can see there is collaterals here. This patient also has the vessel which is occluded, but the collaterals is not good. So this patient prognosis is not that good. This is another patient, collaterals. There is occlusion here, and there is no collaterals at all. So this is the extreme case where the collaterals is very bad. Okay. Next, we come to the last P, which is the penumbra. So how can we assess whether there is salvageable tissue remaining in the brain? So here we can use 3 methods. First of all, we can use what you called as a clinical radiological mismatch. You don't need any hi-fi imaging. Second, you can use what you call as a diffusion flare mismatch. And the third, you might use advanced imaging like MR or CT perfusion. So first we'll see what is this clinical radiological mismatch. So here you have a 56-year-old chap who has woken up with a stroke, and he has come to you with a right hemiplegia, and he has a right neglect, and he is globally aphasic and NHS of 16. So you did an MRI, and this is what you see on an MRI. So here you see there is an infarct in the internal capsule region. But if you look at the clinical picture, he has hemi neglect. So can you get hemi neglect with what you're seeing on the imaging? Can you get global aphasia? No. So that means there is something more which is happening, which is ongoing, which means that he has a large stroke which is not yet seen on the MRI. This can be that means this is an area of the core, and this much area can be the penumbra. Okay, so this is what you call as clinical radiological mismatch. So he had a M1 occlusion, and subsequently when a perfusion scan was done, there was a large penumbra. So actually this patient, you don't need to do a perfusion study. By clinical radiological mismatch itself, you know that there is a penumbra. So that is one technique to look for penumbra. The second is looking at the what you call as a diffusion flare mismatch. So on the MRI, you have various sequences. One sequence is called the diffusion weighted imaging, and the second is called the flare imaging. So this is a patient. If you look at this patient, he has a stroke here. You're seeing it on the diffusion imaging. On the flare imaging, it's not seen. Diffusion is seen, flare is seen. So what is the difference? So this is called diffusion flare mismatch in early stroke. And if there is a diffusion flare mismatch, that means the patient has come to you very early, at less than 4.5 hours with a stroke, and you can potentially treat him. In rare cases, we need to use perfusion studies. So here you give a dye and you inject dye, and then you look at various parameters like cerebral blood flow, cerebral blood volume, and you look at the mean transit time. The mean transit time is the time when you give the dye for the dye to reach from point A to the point B inside the area which is ischemic. So these are the various parameters. And if you look at this, as you know, the penumbra is being maintained by the Peripheral Collaterals and cerebral autoregulation. So what happens is when there is an occlusion, when the cerebral blood flow drops, these vessels will start dilating in the area of ischemia, and also the Peripheral Collaterals will supply some blood. So even the blood flow, even though the blood flow is dropped, blood volume in that area will be slightly elevated. And this is the mean transit time, which will keep on increasing as the ischemia progresses. So any patient with us, if you see on the perfusion, the areas which has a slightly low cerebral blood flow, but a higher cerebral blood volume, that is an area called that means that area is still viable. That's an area called the penumbra. But as you go down and the ischemia progresses, both your cerebral blood volume and your cerebral blood flow will come down. Those are the areas where it is totally infarcted. So when you minus these two areas, you get your infarct code. So that is the gist of using a perfusion imaging. So currently we have actually softwares. We just feed this information. It will tell you like this color mappings, where you have the red, which is the infarct core, and the green is the penumbra. So for example, here it is shown, okay, core 96 ml, penumbra 124 ml. That means it's a good patient, you can start treatment, even though whatever time the patient has come to you. And these are, you can feed this, and on your mobile, you can get these color-coded maps. So at the end, we can either use plain CT with CT angio plus perfusion, or an MRI, what you call as an MRI stroke protocol with MRA and perfusion to get all these 4 P's which we described. So once you have all these P's, next we'll have to see what we can treat the patient with. So before you start treatment, there are 3 things you should note and take action. One is the sugar. So you make sure that the sugar is well controlled, should be below 200. The blood pressure is very, very important. I'll come to it in the subsequent slides, and also do a pulse oximeter. Now, the patient should not have any contraindication. That is, if you are planning intravenous TPA, the onset should be less than 4.5 hours. The deficit which the patient came with should be persisting. And CT, obviously, there should not be any bleeds and no large established infarct and no SH or even a clinical suspicion of a subarachnoid hemorrhage. The patient should not have any history of fever, which can make you suspect a septic emboli. And if the patient is on any oral anticoagulation, the INR should be less than 1.7. And the patient, we use nowadays a lot of neuroanticoagulant. The patient should not be on neuroanticoagulant if he's on them at least for the last 48 hours, and no major surgeries or major GI bleed. And the NHS score should not be very, very high. If it is more than 25, that means your treatment is not going to be effective. And also, if sometimes you have patients in the ward having a stroke, those patients who are on therapeutic low molecular weight heparin is a contraindication, but not prophylactic low molecular weight heparin. And also there are other relative contraindications like being pregnant and post-MI. So these are relative contraindications. So like this one patient we had some time back who was actually pregnant, but we could still give TPA. So even those relative contraindicated cases, we can selectively treat them with intravenous thrombolysis. So what are the treatment targets? So when you treat a patient, what are the things you want to achieve? Coming back to the slide, you have the penumbra and the core. The main treatment is recanalization or restoration of the cerebral blood flow. So basically, there's an artery which is blocked, you have to go in by whatever methods you can, try to re-establish the blood flow as early as possible. So that's the first aim. Equally important is the maintaining or even augmenting the collateral blood flow. So this is something which often gets missed out in the whole hurry-burry. So maintenance of collateral blood flow. And third thing is there are a lot of neuroprotective agents which I'll come to shortly. So coming to the collateral flow, so this is something very simple which we should not miss out. The main thing here is never reduce blood pressure abruptly. So if you have a patient with acute stroke, the BP should not be brought down at all unless if you're planning intravenous thrombolysis or mechanical thrombolysis, you can bring it down less than 185 or diastolic less than 110. If you are not planning any thrombolysis, you are planning to conservatively treat the patient, you need not treat till the systolic BP is more than 220 and the diastolic BP is more than 120. So this is a very, very important, and often we give patients with acute stroke blood pressure with disastrous consequences. However, there is some subgroup of patients you might treat that those are the ones who has a acute coronary event occurring simultaneously, or the patient is having a LV dysfunction or aortic dissection, or a patient who has eclampsia or preeclampsia. So this is a very common mistake, and this is one of the studies which we did some time back, looking at all the general practitioners and what they felt about BP. So 37% wanted aggressive BP reduction in the acute phase, which is a very wrong thing to do in an acute ischemic stroke setting. So you can start treatment if the BP is going beyond those guidelines, and you make sure that you have at least 2 readings before you start treatment, and no administering sublingual calcium antagonist. So also make sure that the blood pressure is, the high BP is not contributed by any pain, bladder, or even raised ICP or hypoxia. So all these things you take care first and then start your treatment. And the best medicines to give for this IV labetalol, you can give it in small boluses. Never give them a big bolus. Just give 5 milligram, wait for 1 or 2 minutes or even 10 minutes, and then repeat it if needed slowly. Okay, so you don't want the PP to suddenly crash and the penumbra can become totally dead. Right. So other options we have is IV sodium nitroprusside or intravenous D-chain drip. So these usually most of the patients settle with IV labetalol. And also you make sure you don't start the patient's pre-stroke medications on the same day. You wait for at least 24 hours after the stroke, and then you start reducing it slowly and not around 25% of the BP per in the first 24 hours after first 24 hours. So don't give him his usual BP medication straight away. Right. So that is about the maintenance of the collateral circulation. The second is the main thing is recanalization or restoration of the cerebral blood flow and reopening of the blocked artery. So here we have intravenous treatment which is available. We have two choices here. One is we can give intravenous tissue plasminogen activator, which we have been using for a long time. We have other choice that is called tenecteplase, which is a bioengineered 3-point mutant variant of alteplase. So you can use either of these intravenous agent for recanalizing the blocked artery. Now, if you look at these two agents, the alteplase, the tenecteplase has a slight advantage over alteplase because it is more fibrin selective. And second thing is it has less inhibition by what you call as a plasminogen activator 1. So when you give all these agents, the agent itself will get inactivated by the body. So the tenecteplase has slightly more resistant against these endogenous agent. And also the half-life, you look at the alteplase half-life is around 4 to 8 minutes. So we have to give it via infusion pump over 1 hour. Whereas tenecteplase, it has a larger half-life, so you can just give it as a single bolus. So these are all slight points which is slightly favoring tenecteplase. Now, you know that we can give these intravenous thrombolytic agents in the first 4.5 hours. But here, even in that window period, the later you give, the benefit is coming down drastically. And if you look at the number needed to treat, if you can give these drugs in the first 90 minutes, your number needed to treat is very good, around 4.5 hours. But as you go down the time window, your number needed to treat increases. So even within the window period, you should not be saying that, oh, I got another 1 hour or 2 hours, but you should be acting as quickly as possible and try to thrombolyze these patients. So we can augment this action of this intravenous thrombolytic agent by doing what you call as a sonothrombolysis. Here what you do is you just connect your TCD machine to your with a head frame and target your transcranial Doppler on the artery which is occluded, and which will increase the possibility of the drug which is working on the clot. So this is one of the articles we have published from our department where we had used this sonothrombolysis for acute ischemic stroke with very good effect, especially in M1 occlusions. Now the question is, even though the recommendation is 4.5 hours, can we extend this window beyond 4.5 hours? There has been 2 studies that looked at it recently. One is called the Wake Up trial. So here what they did was they picked up patients who woke up with stroke and who had diffusion flare mismatch, which supposedly predicting that this patient had a stroke in the within the last 1.5 hours, and they treated, and the results were very encouraging. The second trial which looked at was the Extend trial. Here they used a specialized software to look at the penumbra and the core and treated patients up to 9 hours with IV thrombolysis. Here also there was a benefit seen, but however, these are all trials. Currently we give only up to 4.5 hours. Now, the problem with IV TPA is the vessel which is occluded. So if you look at this diagram, you see here, if you have a vessel which is very distal here, the chance of your IV thrombolytic agent opening up is almost 73%. But as you come down, say M1, the chance of you opening up becomes less. And if you reach the carotid, it's only 14%. That means if you have a patient coming to you with carotid disease, carotid occlusion, even if you thrombolize, there's a 85% chance that your drug is not going to be effective. The second, length of the clot, a clot which has a length of more than 8 mm also has been shown to be of not much of use if you give IV thrombolytic agent. So this is where mechanical thrombectomy devices coming to use. So people have been using these mechanical devices since many years. So initially they were using ultrasound, aspiration, etc. So this is one of the early devices called the Mercy device. So here what you do is you have a catheter which goes into the clot and it pokes into the clot like a corkscrew, and then it just yanks it out. So this is called the Mercy device, which was one of the earliest devices, mechanical devices, which was used in stroke. So let's fast forward this. Yeah, so you just pull out the clot. So that was the Mercy device. Then next came what you call as a Penumbra device. This is like a small vacuum cleaner which can go into the brain artery which is occluded, and then slowly it will start sucking out the clot. So this is a device which we were using very regularly. And then came big trials in 2012 to 2013 using what you call as a stent retrievers. So this is one such stent retriever called Saltair. So this what it does is, as soon as this device is put into the artery, it just pokes through and through the clot which is occluding the vessel and then stents it. Okay, so immediately the distal area which is ischemic is getting blood, and then subsequently once the stent is in place and the distal areas have enough blood, you start pulling out the clot. So that is why it is called stent retriever. So first you stent the vessel, you re-establish the flow, and then you retrieve the clot. So this is called the stent retriever, and this is the latest device which everywhere is being used for treatment of acute ischemic stroke. And this is what it will look like when the clot comes out. The clot will come out with the stent and the flow is established. So these are the major trials which look MR clean escape SWIFT prime, which clearly confirm that superiority of endovascular devices in stroke treatment. And since 2015, guidelines have shown that for any patient with a large vessel occlusion, that is an M1 carotid or a basilar artery occlusion, you have to use this stent retriever devices with a patient who is more than 18 years. And if you can achieve a groin puncture within 6 hours of the onset of symptoms. So the important thing about these devices is, earlier there were a lot of contraindication for using these devices, like bleeding, etc. In those patients also, because there is no thrombolytic agents which is being given, we can safely use this and remove the clot. So this is one of the series we had using these devices in patients who are pregnant. Because as you saw, pregnancy was a relative contraindication, especially late pregnancy, we can use these devices safely. Now, again, here people have looked at whether, so the recommendation is you can use this device within the first 6 hours. But again, there have been trials which had looked at whether we can stretch this window beyond 6 hours. So there were 2 trials called the Dawn trial and the Diffuse trial. And one of these trials, they extended the window up to 24 hours. But all these trials have used sophisticated software to calculate how much penumbra to be saved, etc. So what you see now is earlier it was all time, like 4.5 hours, 6 hours, 12 hours. So now that is slowly being shifted to what you call as a tissue clock. So you look at the in the brain and see how much tissue is there to salvage by advanced imaging and then start treatment. Now coming to neuroprotection. So there has been a lot of trials going on, neuroprotection in stroke. So there's been a lot of drugs which has been developed and marketed aggressively, like citicoline, edaravone, all those things. But none of these drugs has been shown to be of any benefit, and there's no point in using any of these drugs till date. There are again some more trials which might come out in the next year, which might give us newer molecule which may be beneficial in this treatment. So no neuroprotective agent has been found to be of any use. Now coming to the last part of the talk, which is surgical intervention in acute ischemic stroke. So here you have a patient who has come to you a bit late. He has come to you around to the stroke. So you can see there is a large area of infarct here, already established infarct. Around 24 hours late, another 6 hours later, he starts dropping GCS. And then you, as a life-saving measure, you have to do hemicraniectomy. Okay, so these are large strokes called malignant MCS stroke. So in your practice, you will see 10% of all ischemic stroke will be malignant MCS stroke. And usually these strokes are caused by the occlusion of either the internal carotid artery or a proximal M1 segment of the middle cerebral artery. The mortality here is very high as 80% if you give them only medical management, and you have to do decompressive surgery to as a life-saving measure. So there has been a lot of trials looking at whether it's worth doing surgery on them. The earlier trials called the decimal destiny Hamlet, and there has been newer trials which are looked at it. And if you look at this meta-analysis of these trials, there is a definite benefit if you do surgery from the survival, but the patient's MRS may not be that great. So here it is at 12 months MRS, they are comparing 0 to 4 versus 5 to 6. So MRS of 4 is not a great thing, especially in a country like India where you don't have any rehab facility and all that, but still you can be offered as a life-saving measure for a given patient. So in effect, what does surgery do? Suppose you have 100 patients who has a malignant, coming with a malignant MCI infarct. If you do surgery, if you don't do surgery, 70% of them will die. If you do surgery, only 30% will be dying, but the remaining 50% can have an MRS of 4 or more. So that is what you should be telling the relative. You can potentially save their life, but they maybe become bedridden and you will have to take care of them. So ready for that, you might offer them surgery. Right. So this is what we do in CMC, Vellore. So if a patient comes with an acute stroke of less than 4.5 hours, immediately you do a plain CT scan. If the plain CT scan shows no contraindication, no bleed, no large established infarct, you immediately start in intravenous thrombolysis. As so, while the thrombolysis is going on, you shift the patient for a MRI. That is, you do a diffusion weighted MRI flare and MR angio. You look whether there is a large vessel occlusion. If there is a large vessel occlusion, you immediately take them for a mechanical thrombectomy. If provided the patient is having still the NHS score is more than 6 and the time to achieve a groin puncture is still less than 6.5 hours. Right. What about patients who come like wake up with stroke or you don't know when they had the stroke? These are the patients you should not do a CT immediately. Better to do what you call as a MRI against stroke protocol and look for what you call as a diffusion flare mismatch. And if there is a diffusion flare mismatch which is significant, and then you can start treatment with IV thrombolysis. or if there is an occlusion, you can do a mechanical thrombectomy. And all patients who go for a mechanical thrombectomy, we have to inform the relatives regarding possible decompression, because not all thrombectomy is going to succeed. Now, so in short, we can say that this is one of the acute ischemic stroke is one of the commonest medical emergencies which requires teamwork. Okay, so we work as a team with radiology, starting with the MRI technician, CT technician, and you have to quickly evaluate the patient and take a decision regarding treatment. And the time window, as you saw, is moving from a clock time based to a tissue time based one. And mechanical thrombectomy should be offered for all LVO stroke, that is large vessel occlusion stroke, within the 6-hour window period. And no neuroprotective agents is going to benefit your patient. And if the patient requires surgical intervention, you have to involve the family and take a decision regarding surgery, decompressive surgery. Okay, thanks. I'll take any questions now.
Are there any questions? So one question on secondary prevention of stroke, and if patients have gone as we usually start them.
Yeah. So I didn't include that because this itself was. So basically, secondary prevention of stroke. If you're thrombolizing, you start them after 24 hours. For right now, the recommendation is you give double antiplatelet agent for the first 3 months, then 21 days, sorry. And unless there is a large artery occlusion, so intracranial atherosclerosis, all that, you can continue. It depends on what you want. There's no clear recommendation, but for all the other stroke, first 3 weeks you give double antiplatelets, and then if it is a lacunar infarct, definitely you should not give more than 21 days. The large vessel occlusions, large artery strokes, we tend to continue them. There's a new trial which is looking at it, whether it's worth giving them double antiplatelets for a long time or not. So.
There are no questions. We'll end the session. Thank you so much, sir.
Thank you.